Hello, I'm AJ, Occupational Therapy.
Hi, I'm Marielle, physical therapy.
So we have case number 5. Our client is a young male in his 20s to 30s who recently suffered a left CVA, which means that he could have some possible issues in communication, logic, and judgment. It seems that his receptive language is intact, but it's a little bit difficult to understand him, so the expressive is something that we're going to try and work on as well. He's able to follow one and two-step directions when given, but also shows impulsivity during action. He requires moderate verbal cues and max tactile cues when working to ambulate to the sink. And he's also experiencing a posterior pelvic tilt, which brings up some safety concerns on my part. He's oriented times 3, but is going to need verbal and physical cueing to learn how to safely transfer and perform his ADLs. So then for the test and the measures that the occupational therapy department will do, first we want to complete an occupational profile just so we can know his background, his family life, and the environmental factors that are going to help guide our interventions and determine what his areas of needs are. I'm also going to assess tone, possible contractures, and subluxations as well. And then as far as standardized assessments, I'd like to do the Barthel Index just to determine his level of independence in his basic ADLs like feeding, bathing, grooming, and dressing. And we're also going to do the stroke impact scale. So this is just kind of to get an understanding of how his stroke has impacted his quality of life and his perception of self, so that we can just be aware of his mental health attributes that are going to be important when we're trying to motivate him and understand his reasoning for therapy.
Okay, yes. So the patient is a young male, as you stated, that had a stroke recently. From what I saw, he has a nasogastric feeding tube, but doesn't appear to be connected to any intravenous lines or machines. So that should be we should be able to deal with that better. The patient is thin and frail and shows generalized weakness, which we'll need to address. And his left eye remains shut throughout the treatment, so he likely will have some kind of visual deficit that we need to look into a little bit. And then patient also presents with loss of mobility of the right upper extremity and limited mobility in his right lower extremity. So while he's transferring from sitting to standing, he's able to use momentum to stand, like pushing off with his left arm. And so, but then when he's standing, he stands so quickly that he has unsteadiness when he stands. And then he also is able to initiate gait with his right lower extremity. So he tries his best to like start the movement, but then he requires the physical therapist to aid in the movement to complete it. So she'll need to. It showed that she needed to stabilize his knee to prevent him from buckling as he was weight bearing on it. The patient also had showed hesitancy and delayed movement, including initiation of gait to and from the sink, and upon return to sitting on the edge of the bed. Um, he walks with his head down and his shoulders rounded and demonstrates excessive sway when standing. And he presents with lack of coordination and or abilities to sequence the movements, as demonstrated when the physical therapist needs to constantly give verbal and tactile cues with him. And then finally, at the end of the video you could see he tries to attempt to sit down quickly, but then he's able to self-correct when the physical therapist tells him to just to keep going, to move to be in line with the bed, so that he does try to rotate so he's more in line with the bed, but then he suddenly stops and then abruptly sits down because of fatigue. So that caused him to be sitting on the edge of the bed at an angle with his left lower extremity more supported than his right, which could be a safety issue as well. So for our tested measures, we were going to observe the patient, like his posture and his alignment in both standing and sitting. We're going to also address his cognition, so any to assess his alertness and orientation, as well as we wanted to look at his executive function using the Montreal Cognitive Assessment, and we wanted to also continue to assess the patient's range of motion and strength, as well as tone using the modified Ashworth scale. And then we wanted to perform a neurological examination in which we were testing sensation, including vision, deep tendon reflexes, coordination, and balance, both static and dynamic. And then we will continue with using the Fergelmeyer assessment tool to assess his sensory motor impairments that occur because of stroke, and then we wanted to attest his ability to perform functional activities, including bed mobility transfers, using the functional independence measure.
Good.
Okay, so based on the ICF model, so our patient had a stroke. For our impairments, we noticed that he had loss of function of his right upper extremity and weakness and limited mobility of his right lower extremity, as well as impaired balance and delayed timing of movement.
And some other things that I saw is he definitely had some higher level cognitive impairment, so judgment and sequencing are a problem. Also, a little bit of lack of self regulation because he didn't seem to get upset in the stressful situations. As you mentioned earlier about the eye, there's some decreased visual acuity and visual field functionings, and then also some impaired kinesthetic awareness of where his body is moving in space.
Okay, and then for his activity, some of his abilities are that he's able to initiate the movement of the affected lower extremity, and he has the function of the left upper and lower extremity, so that'll be very helpful for him to with the movements and such.
Yeah, he's also able to correct his movements with verbal and tactile cueing, so that should make him a good candidate.
And then for limitations, some we had was that he had difficulty transitioning from sitting to standing, and he had difficulty ambulating short distances without fatiguing or having loss of balance.
Some other limitations that I had seen were the impulsivity when he was ambulating, and also the decreased sensory functions on his right side, so those all kind of lead to safety issues when we were talking about his discharge.
And then in terms of environmental, so some facilitators we've noticed was that he does have a very compassionate nurse that's attentive to him, and as well as he has a very attentive physical therapist who's caring for him at the moment.
That's very good. I've also noticed that the patient has a lot of family and friends that support him and have come to visit him so far.
And then his barriers are the gait training. It takes place in a small, cluttered room, so that could be a safety hazard for him.
Yeah, also the hospital environment is obviously not the same as it's going to be when he is discharged home, so I'm kind of worried about his ability to generalize the skills and transfer them over to home. And then he isn't really used to waking up as early as he is for physical and OT, so he's having a hard time staying motivated to participate.
And then some of the personal factors, the facilitators, we did note that he is a young male that's motivated to return to prior level of functioning.
He's also got the ability to communicate his wants and needs, although we can't really understand his language that well. We can tell what he likes and what he dislikes. And he's able to sustain attention during the activities that we're working with him on.
And then some of the personal barriers we found was that the patient that does demonstrate hesitance and fear of falling, and then he also can be impulsive at times, as demonstrated when he abruptly sat on the edge of the bed without listening to the therapist's recommendations.
Yeah, so some of the barriers that we have are mental health concerns due to the traumatic event and being away from his family, so we need to just be aware of the possible signs of depression when we're all working with him.
Alright, so for assessment, our problem list, we determined that he has lack of strength and mobility of the right upper extremity and weakness and limited mobility of the right lower extremity, as well as difficulty maintaining balance and coordinating movements, and he shows some buckling of the left lower extremity when weight bearing onto it.
He's also got the decreased sensation on the right side of the body, like stated earlier, and also the decrease in higher level cognitive functionings for judgment and safety. So for OT, our plan of care, we're going to see him 4 times a week for 1 hour for the duration of 3 weeks, and then we can reevaluate then. And You said that yours would be 4 times a week for 1 hour for 4 weeks, correct?
Yes. And then for discharge plan, we were thinking of, based on his current impairments, including difficulties with transfers and performing ADLs, he'll need to be discharged from acute care hospital into an inpatient rehab facility. So this facility will emphasize rehabilitation that allows the patient to make enough functional gains to be able to return to home without being at risk of falls and any other safety issues.
That sounds good. So from the inpatient rehab, we do think that he should go into outpatient when he's demonstrated progress in his functional ability and safety awareness, and then he can just continue outpatient at home.
Okay, and then we noted for the PT goals, we'd like for him in 15 days to be able to perform sit to from stand 7 out of 10 times with proper foot placement and control upon descent, modified independent in order to transfer from the bed to the bathroom safely. And then in 4 weeks, we want him to be able to ambulate 200 feet with supervision using his quad cane in order to safely walk throughout his home.
Okay, so our biggest ones are going to be looking at bathing, dressing, and safely transferring. So what I really want him to do is to be able to address his upper and lower body while seated at the edge of the bed with min assist in 3 weeks. And then also be able to transfer safely from the chair to the shower chair with mod assist using whatever equipment that you give him in a week. And then be able to complete lower body and upper body bathing while in the shower chair with min assist in 1 week. And safely transfer in and out of bed with mod assist with his quad cane in a week. As far as the interventions that we want to use, I'm going to try and do some NDT handling techniques to address the posterior pelvic tilt so we can make him a little bit safer and address the visual issue so he's able to look up. And then also, along with that, using the PNF movements just to increase the upper extremities functional movement patterns.
And then for PT, we like to just perform more great gait training using his assistive device, and also perform stair training. Should he need to be able to enter his home that have steps, or if he wants to enter a room above, he'll be able to. And then we want to have we want to strengthen his lower extremity so that he's able to transfer better with his lower extremity. So we want to strengthen that by sit to stand and weight shifting and such.
And then for the right upper extremity, I was thinking about putting on an air splint so that we could do some strengthening exercises to help decrease the possibility of subluxation there.
And then in regards for the patient, we'd like to try to educate him about safety and sensory issues related to IADLs and such as cooking and home maintenance. We'll see how his cognition is at that time, but that's something we'll want to address.
And then just to assist in his goals, I'd like to get him a couple of adaptive pieces of equipment like the shower chair, a button hook, and maybe teach him some one-handed techniques so that he's able to dress and bathe himself better.
And then we want to also provide caregiver education so that he's taken care of at home in a safe manner, and he's performing his home exercises at home.
And then, so during the evaluation, I'll probably talk to him about the discharge plan and when he gets home and ask him what his house looks like and what kind of equipment he has there. And as we get closer to discharge, we can just try to start modifying the home for him so that it's safe for him to be able to go. I'll also do some top-down approaches looking at his activity analysis of the basic ADLs just so we can figure out where on the function-dysfunction scale he falls and how we can help him there. And then lastly, anytime that we are performing any basic ADLs, I'm going to have him weight bearing on that upper extremity to help get some proprioceptive input and encourage the recovery of it.
And then finally, we want to try to address constraint-induced movement therapy approach, in which we'll try to have him use more of his affected upper extremity to perform functional mobility type of tasks.
Well, that sounds good. Seems like we have a plan. Hopefully we can get him home soon.
Yes. Thank you very much.